Thank you so much for joining us today. I'm thrilled today to be able to interview Dr. Deb Mayer, one of the recipients of the Ellen Stovall Award, which we awarded to her last night. We are so thrilled to give her this incredible honor that is so well deserved. And before we get into our discussion, I wanted to read a little bit from the nomination letter of Jean Moseley, who is a cancer survivor and an oncology nurse and someone who Deb helped through her cancer experience. And so this is what Jean Moseley wrote. I speak from the heart when I recommend Dr. Deborah Mayer for this prestigious award. Her professional experience has been invaluable to me during these last 15 months. Although I'm aware of her numerous publications, awards, and recognition in the field of cancer survivorship, I am most impressed by her vigilant support of me as a patient traveling through unknown territory. I remain eternally grateful for her professional attention to my diagnosis and her willingness to be with me even from 3,000 miles away. There's no question that my cancer care and experience have been improved by her participation. I'm honored to support her nomination for the Ellen L. Stovall Award and believe that she is eminently qualified to receive this award. Thank you, Deb, for joining us today. I wanted to start with that because, when we get incredible nomination letters from colleagues, but to me, the most important ones are the ones from patients. And despite all of your research and leadership, you still help individual patients. And so I thought that was a really nice tribute to what you do to help people as they go through this journey. So congratulations and thank you so much for being here.
It's just a wonderful award, and having known Ellen and worked with her since the 90s, it's very meaningful to have received this.
Wonderful. So I just want to start with, tell us, how did you decide to focus your research and practice on cancer survivorship?
Well, I have been involved in clinical trials my whole career. I started out very young as a chemotherapy nurse, but we always did clinical trials. And then I became a nurse practitioner. And what I was seeing is, and what I realized is, we see people in snapshots. They come in for a visit, we see them, we treat them, we evaluate how they're doing, and then they go home. But they live the video. And that video experience is often very different than what the snapshot looks like. And as I made in comments last night, my patients taught me what was important. They told me that it wasn't just about treating their cancer, but it was about helping them manage their cancer experience. And so I really listened to that and learned from them. Every patient I learned from their own stories, but also from how to take care of them. And that built one upon another for years. And that's actually why I published, was to share those experiences so that other nurses wouldn't have to start all over. And that was very important to me.
So now, as you are retiring, what do you see as the biggest gains that we've made in how we deliver survivorship care in the United States?
Well, I would say we have a long way to go in delivering survivorship care, because we really don't have a system of survivorship care or a process where we really pay attention to what we're doing there, other than continuing follow-up studies, except for some places that are really striving to do that. So I think we really need demonstration projects and other kinds of things that will help us show what are the better ways to deliver survivorship care, because it's really follow-up care after treatment for those who are lucky enough to stop treatment. There are another group of patients who continue on treatment or go on and off treatment. So although my comments may sound like they're only for people who are off treatment, these are issues of all survivors, whether they're on treatment or off. So I think we need to learn different ways to address their needs. We do a chemotherapy class before you start chemotherapy, but we don't routinely do the chemotherapy class for when you stop chemotherapy or stop radiation, and tell people what to expect, when their side effects are going to get better, when they might be returning to what most people don't like being referred to as the new normal, because they want their old life back. But there are adjustments, and it does take about a year to recover if you're off treatment, and then to figure out what this new normal looks like. So I think we have a lot to learn about models of care and who needs what, because it can't be a one size fits all, because everybody's experience, their cancers and their treatments are different.
So your comment led me to another question I have, which is, the quality or intensity of survivorship care just is so variable. It depends where you go. And so you have some academic centers that do a wonderful job and others where they don't. And then you have some community practices that have good survivorship care and others that don't. And I know, you had the experience of trying to get, of really getting a survivorship clinic off the ground. And it was sometimes, I think I've heard you say, a challenge. It really takes somebody with persistence and vision and dedication to it. So how do we improve so that it's not such a patchwork and it's not so dependent on where you go? I know that, it's really hard to have standards of care that are delivered across the country. I mean, so much of how any healthcare is delivered depends on where you go. But how do we make sure that you don't have to go to the right place to get good survivorship care?
Well, I think you need to think about a top-down and a bottom-up approach. So every time I delivered a survivorship care plan to somebody, I would say, if you found this helpful, please let your doctors know, because then they're going to want that for more of their patients.
Mm-hmm.
So that's sort of the bottom up of talking what their needs are and about programs or services that they had that were helpful. We also need things like the Commission on Cancer that does create standards that institutions are interested in meeting to deliver quality cancer care. But what that looks like is going to depend. I think we need more research, more funding for research in this area around models of care. We need more research on sort of the long-term and late effects of adults. I think we do better with kids than we do with adults in some of those areas of what are the long-term and late issues that somebody may face. You don't want to put it all on the individual to be their own advocate, because that's really passing the buck. On the other hand, we want people to be educated about what they should be receiving, so that if they're not getting, they can be asking about it. I also think that we need, mostly with medical oncologists, some with radiation oncologists and surgical oncologists, to get them to lift their head up and look beyond the treatment period and to say, I've done this with my treatments as far as side effects, and I need to be following people and helping them until these are either resolved or mitigated to make them as manageable as possible, while partnering all along with the primary care provider. Because really the long-term care of people who've had cancers with their primary care provider, and many times they feel left out or cut out of the cancer care part. And so we need to look at the very basic issues from time of diagnosis. If the person doesn't have a primary care provider, get them one. And if they do, make sure they're getting clinical notes. They're still seeing the patient for management of their comorbid issues. And there's communication between the cancer team and the primary care team to how to do this. And it's very hard in a system that is not as functional as it needs to be, which is a kind statement.
Yes. I mean, that implies that there actually is a system, and it sometimes seems like there isn't. I mean, if you're a cancer patient or cancer survivor who wants to find that kind of team approach but doesn't have it, what would you do? How do you go about making sure that you have providers that will work together?
Well, one is you ask and make sure that your primary care provider's name is on record, and ask that they're getting the notes. And when they visit their primary care provider, ask if they're getting the notes. We did a small pilot study to see if the survivorship care plan we sent electronically actually got to the primary care provider, and it did. We also, have a frank conversation with your primary care provider. Are you comfortable taking care of me after treatment? And are you talking to the oncologist? Some very basic questions that may prompt them to do a little bit better job. We are all trying. It's not that anybody doesn't want to do this. It's just that it's in a system that doesn't promote and support these kind of collaborations. I think that's going to change over time, but for all of us, it's not fast enough. It needs to be better, faster.
Right. And when we have done our survey, our state of cancer survivorship survey, we hear from patients that, some of the more concrete issues are being addressed well, nausea, vomiting, things like that. But all of the things that are less concrete, less easy to deal with, or, like you said, I think sometimes the oncologist focuses on the specific physical side effects. And then the other things like fatigue, depression, anxiety, things like that aren't addressed as well. And and they don't feel like they're getting the support they need from their healthcare team on those issues.
As a clinician, I always like to normalize that for people that I'm seeing, to say that normally a lot of people experience fatigue that goes on longer than they expect, that interferes with their resuming their normal activities. Is that happening for you? Normally, people have found that during treatment, they may have lost their sex drive or interest in sex or intimacy. Has that happened for you? And so I try to normalize it because you're educating people along the way, and they may not talk about it at that time. There's also a lot of resources like on the NCCS website or ASCO's website or ONS's website or the American Cancer Society that gives information, because I would often give a person a book about after breast cancer treatment, because it's something you just may want to refer to or learn more about as time goes on. The other thing is, at this point, many people like talking to their peers. People have been there and done that because they are the ones that who truly experience and understand what they're going through. And so having a cancer buddy or friends or participating in a support group or an online community is often a place where those kind of conversations can go on, including what other questions to be asking or what other services to seek out. There's the Live Strong at the Y is one such program that people can look for if they have that in their community.
That's great. I think normalizing it is so important because a lot of times we hear it's just that they didn't know to expect it. And so when you say that this is something that happens to a lot of people, that gives people a little bit more comfort that, you know, they're not an outlier to have this happen to them, and also opens the door to talk about it, because we also did hear that sexual issues are ones that are, you know, of a high concern, but very often not discussed. And so their patients aren't getting the support they need to deal with that. And so I think that that's really important.
We talk to people about their bowel movements a lot easier than we do about their sex life.
Right.
That's just the way it is. But I think that we need to be talking about those things, because if you're taking care of the whole person, that somebody's sexuality, as far as who they are, their roles, their image, their self-image, all those things come into play for that. And that really is important. Again, you know, by normalizing it up front, it may not mean that they want to talk about it, but later on they can. And I've had, you know, usually during my visits with people talking about these things, there would be such laughter. We would get such a kick out of things. People are like, wonder what's going on in there. They're laughing so much, but it doesn't have to be all this serious
Right.
stuff that way.
Mm-hmm. I also really appreciate what you said about not passing the buck, because I do think, you know, the patients that we talk to are very empowered patients. They know how to do the research and find, you know, the answers they need, or at least what questions they should be asking. But I think if we put that burden on patients, we're not serving everyone, because not everyone has that interest or ability to do that research. You know, even people who have, you know, maybe have the health literacy, or, you know, once they get that cancer diagnosis, they, you know, may shut down and just want to put their hands in their healthcare team and not have to be. I heard somebody say recently, you shouldn't have to become an oncologist to get good oncology care. And I think when we, you know, I think we have to keep empowering patients at the same time we're making the system work for people, whether they feel that level of empowerment or not.
I was a terrible patient, terrible. I knew that stuff, but I didn't know enough, and I had never really experienced it myself when I had my own cancer. And I was terrible because I just was focusing on the wrong things, or, you know, whatever was going on. But I realized at some point I had to trust my team, and I had to be the patient, because I couldn't be the patient and manage my own care. I mean, that wasn't really helpful. I also think that there's a real issue with family and friends when treatment ends, because everybody's there, they rally, they know how to do that. I'll drive you to your appointment or bring you a meal or whatever. But when treatment's over, everybody thinks, okay, it's done. I'm going back to work and not worrying about it. And then they don't understand why, when you're due for your next mammogram or pap smear or colonoscopy, you are getting anxious again or having experience, you know, concerns. And I always tell people before their visits for follow-up, that's all going to come back. And I use this theory of illness in the foreground, background. And my patients have told me they really like it, which is, while you're diagnosed and being treated, the cancer's in the front seat of the car with you and telling you where to go and not allowing you access to your own GPS. When treatment's over, it's in the back seat, but you can still see it in the back, the rear view mirror, and maybe
Mm,
even feeling it breathing on your neck. But over time, it gets out of the car and it's in the rear view mirror further back or on the side, but becomes eventually a speck on the horizon. That there are cancer-free days you don't even think about it. And then you're due for your annual checkup or coming back, and it's back in the front seat.
mhm.
And so what family and friends is, they don't understand that dynamic. When they're out of the hospital, they're not the cancer patient, but when they're coming into the hospital, it's back in the front seat and it stirs up all of those things again. And so that's why our other people who've experienced this come into play, because they do understand that in a very different way. And I often tell them the week before an appointment is no time to do anything big like sell your house or quit your
Mm.
job. Wait until the week after when you find out everything's okay.
I love that analogy, though. That's really helpful. I'm sure that can be helpful if people use that to explain to their friends and family, like why this is something that, they can't put it completely out of the car yet. It's going to be there in the back seat.
Yeah.
So you mentioned your own cancer experience. How did that change how you approach cancer survivorship and your professional interest once you were in the situation of being a patient, even if you started out as a terrible patient until you learned how to hand it over to your healthcare team?
So I was interested in survivorship way before I experienced my own cancer. And I mean, when you're young, you have this magical thinking because you're in the field, you're going to be protected from it, and so is your family. And that's not true. But uh, I think that when I work with people and they know that I've had a similar experience, we can talk about things a little bit differently. And I can say things a little differently. I remember doing a focus group with other women with breast cancer, and we could talk about our surgeries and reconstruction or implants and prosthesis and things differently, and have a great time laughing about that they might not have loosened up enough or shared some of those things in the same way. So I think it helped me create a stronger bridge between myself and the people I care for. I also think I paid a lot more attention to the waiting that goes on in cancer care. It's one thing to say, we're going to call you for with your test results. I don't do that anymore. It's going to be, if I haven't called you by Tuesday, please call me.
Mm-hmm.
Being much more specific in instructions, much more specific. Instead of, there's so much uncertainty in cancer care and what's going to happen and when. We can be more specific and then empower people about following up. Make sure if you haven't heard from me, then call me on Wednesday or email me or whatever. So I think that has made me more sensitive to those kind of things as well. It also makes me think about things like work and either if you haven't left work, how are you resuming work or reentry to work? It allows me to think about other kinds of things in a little bit more nuanced way than I did before.
Mm-hmm. Yeah, I can imagine that. I mean, all of your training doesn't really give you the experience of being in that seat until you're there, I guess. So once you are, you're going to see things through a different light.
Fatigue is a classic example of that.
Yeah.
No comprehension until you've experienced that kind of fatigue then you start wondering, is something wrong? Am I going to be okay? Can I do this? It just that's the biggest concerns, obviously, for people afterwards are the fatigue, the energy recovery, mental status, and being clearly thinking as opposed to that sort of fog people may have.
Mm-hmm.
Those are some of the big ones that people consistently worry about, and yet we don't necessarily acknowledge it enough.
Right. Yeah. And you can't understand unless you've experienced it.
Mm-hmm.
So you talked about cancer care plans or survivorship care plans. Tell me a little bit about your view of what we need to do with them and to make sure that they're effective. And I know we've talked about this before, but I'd love for you to just share your views on that.
So I think survivorship care plans are a great idea. I think they got off on the wrong foot. Healthcare is notorious for being slow adopters for new ideas and do not welcome new things to go into the workflow of how we do it.
Right.
And the research that's been done does not always show strong impact to make it worth thinking about how to do it. If this were easy to do, we wouldn't be having these conversations. It just would have been implemented, just like a discharge summary or the after visit summary for a patient when they come in for outpatient visit. You just press a button and it happens. If it were that easy, we would have never had conversations about it. But it isn't, because our healthcare records aren't that easy to integrate. We have to make sure they're correct. We have to review it with the person. My feeling is it matters because it's a patient education tool, and we do have strong evidence that says by doing more than one method of delivery, not just talking, but sharing a piece of paper with it in writing, helps with understanding and retention. That reason alone, we should be doing this. But I also think it's too little too late. My own personal preference is we should be doing a care plan up front, where we give the person a written document that has their cancer diagnosis, stage, and any other pertinent information in the treatment plan, not just a calendar of when you're coming in and when you're getting your blood counts, but a written document so that they know what's going to happen. And then this is the bookend to say what actually happened and how it went and what's the next step. I had people who said to me the only way they knew what the next step was when they paid their copay. It said on the bottom of the slip when their next appointment was.
Yeah.
These were two people listening, and they both came out so overwhelmed. We also know that you retain very little of what you've heard.
Right.
So I keep asking providers, why do you keep talking when you know they're not going to remember this? And so the other thing that I recommend, especially with new phones, is encourage people to record the visit.
Mm-hmm.
And then they can share it with their family members, and they can go back and listen to it again so that they can understand and hear it over until they write down questions or look up words or do whatever. And so I think those are two tools. We should be recording visits if that's helpful and useful for the person. They can share it. I've done that with my own family, and it's really made a big difference, as well as giving them something, even if it's just drawing pictures or writing things down on a piece of paper. We all need that. Nobody can retain everything we're being told.
Right. I think even if you're not dealing with a serious diagnosis like cancer, it's hard to retain everything. But then when you're faced with that and that you have the added stress, you don't hear everything.
Absolutely.
Well, we totally agree with your recommendations on care planning, and that it should start from the beginning, and that the survivorship care plan is really just a bookend. So I didn't pay you to say that, but I really appreciate it, because that's exactly what we advocate for. Thank you so much for your time today, and thank you for all that you've done for cancer patients over your long and prolific career. And I appreciate everything you've done, and I hope that we get to continue working with you going forward, even as you retire and take a step back. Hopefully you'll still be around for us to tap into and really share your wisdom.
Always. And thank you so much, Shelley. And I so appreciate everything that CCS does, because that is so needed. And keep up the good work. Thank you so much.
Thank you. Have a wonderful day.